Vas-y, Robert.
Okay, good morning, everyone. This is Dr. Avram. I'm surrounded with Dr. Lee and Dr. Risset from the Montreal Heart Institute. We are presenting today the case of a 65-year-old gentleman known for hypertension, type 2 diabetes, who has had angina for the past 5 years. And recently he had accelerating symptoms of angina that went from class 2 to class 3. He had a coronary angiogram done 2 months ago, where they tried to dilate the proximal left anterior descending artery in the first diagonal. However, they were not successful, and the patient was sent to us for assessment for surgery or vascularization versus PCI. So you can see the previous angiogram. Previous angiogram demonstrates a heavily calcified proximal LAD lesion, a heavily calcified, almost subtotal second diagonal lesion, and there is also a mid-LAD JCTO score 3, 100% chronic total occlusion. That's also heavily calcified. We can appreciate that there is a blunt tap, there is a side branch, so the diagonal is originating from the first, the CTO, and the occlusion length is greater than 20 millimeters. There's some tortuosity and there's heavy calcifications. There's no safe retrograde access for the CTO. There's collaterals that are provided by the RCA. However, those collaterals are epicardial in nature. Therefore, there's no really safe retrograde access for the CTO.
45-25, s'il te plaît.
In the previous angiogram, they tried to dilate the diagonal, but you can see there's some wasting on the balloon in the second diagonal, and they stopped and they sent the patient to our institution for discussion for PCI versus surgery. Next slide. Next slide. So we review the films with the patient and the different options. For the patient, he had some accelerating angina, but he had a normal ejection fraction and anterior ischemia on the MIVI. He did not want to have coronary artery bypass graft, did not want to have a median sternotomy, and want us to do everything we could percutaneously. We divided the problems in two. So there is a prox LAD with a second diagonal lesion. They're heavily calcified, but they're patent. And there's also the CTO of the LAD. Today, our plan is to open the proximal LAD and the second diagonal with some calcium modification techniques while using intracoronary imaging based on the Renovate Complex PCI trial that have shown superior results and lower MACE events with the use of intravascular imaging for complex PCIs like this case. For the CTO, since it's a JCTO score 3 lesion, we'll attempt to treat it medically and we'll reassess the ischemic symptoms in 3 months as an outpatient. And then at that point, we could either attempt CTO PCI or the patient could also be a candidate for minimally invasive coronary artery bypass graft using robotic surgery, which is an option at our institute and does not involve the use of median sternotomy. So our plan today is to go femoral using a 7 French femoral axis with ultrasound. We will use a 7 French XB 3.5 guide. We will wire the LAD to the first diagonal with a run-through, and then we will shuffle in a Corsair to exchange the run-through wire with the orbital atherectomy wire.
Gauche.
Then we plan to do PCI with drug-eluting stents of the prox LAD and the second diagonal, and we'll follow up the patient's symptoms ischemically. So we are live with the patient and we obtained femoral access. We have redone the coronary angiogram of the left coronary, and the patient had a previous plain old balloon angioplasty of the diagonal that was unsuccessful. And during the present angiogram, the second diagonal is almost subtotal. So we had the issues wiring with the run-through, but finally it passed, and we shuffled in a Caravel microcatheter. But the Caravel was not able to get past the lesion in the second diagonal. And we're currently with the Caravel, and we have a Fielder XTA, and we're trying to regain access to the vessel because our previous attempts with the wire were going subintimal. Dr. Ali, do you want to?
So, welcome everyone. Thank you for attending this great session. We hope this case will be enlightening for everyone. This is a tough case, as Robert said, JCTO of 3, previous attempt of a PCI, failed PCI, which I think left some a much more severe lesion in the diagonal than we anticipated from the previous angiogram. The lesion that they managed to pass initially has restenosis. As you all know, restenosis rates are much higher with plain old balloon angioplasty, especially in calcified lesion. And I suspect that with the PCI POBA that they did in the diag, prox, and mid segment, left maybe some chronic dissections that we have sort of ran into some more challenges wiring. The run through went through, but none of the microcatheters. We made a choice of taking the Caravel catheter as it was much smaller, and it would allow us to squeeze our way through the subtotal LAD test. So I think some of the issues right now is trying to get the micro through, and we have to consider the fact that some of the previous attempts left some dissection planes that we have to manage our way through to accomplish what we want. Ultimately, this is the challenge right now. I think we've managed to pass through the lesion, but it's to regain intraluminal access. Test.
Our initial plan was to do orbital atherectomy of the lesion due to the size of the vessel. Obviously, the lesion is subtotal, so no intravascular imaging would have been possible in this lesion preemptively. However, just by repeating the angiogram today, we, like Dr. Lee mentioned, we found that the lesion has restenosed, and we don't think the lesion caliber would allow the passage of the orbital atherectomy. So our plan now is to do ROTA with a 125 and 15 millimeter burr up front. But in order to do this, we need to be able to cross the lesion with the microcatheter to swap the fielder for the ROTA wire. So that's what we're attempting right now.
So I think the wire is subintimal, but
yeah,
we're trying to get our way through the subintimal planes. Maybe if I don't know, for the sake of the audience right now, we're in March 8th, with the recent ACC release of the Renovate Complex PCI. As Robert mentioned, our plan was to do some imaging, and with the imaging, I think the outcomes, and the Renovate PCI was released yesterday, published in the New England. And as you all know, imaging was already heralded as something of a game changer initially, but without necessarily the randomized data. And yesterday, when it was published and presented at the ACC, I think a bit over 1,000 patients were in the intracoronary imaging versus 560-ish patients in the angiogram-guided PCI. It showed that the composite endpoint was much more favorable for intracoronary imaging, 7.7% versus 12.3% test. So this is our intention, I think, to go forward and try to wire this bifid LAD and try to get our way across the different planes of this dissection that was left, I think, from previous attempts. As you can see, from the angiogram, there is the calcium has been modified with subintimal penetration of the wire. And ultimately, that doesn't stop. And this is actually favors us to even go more towards rotational atherectomy than orbital atherectomy. As you all know, orbital atherectomy is not recommended in dissected vessels, whereas dissected vessels, even though in the IFU it won't be mentioned for rota, we are much more comfortable doing rota within dissected vessels. So this is ultimately the strategy that we had planned. When we previously did the angiogram before, that's where we wrote in the slides that orbital atherectomy would have been a nicer strategy. We didn't anticipate the tightness of the lesion that we would have in the diagonal, especially in its proximal segment, when the initial team had managed to get their way all the way through to the mid segment of the diagonal. So right now we've went from a workhorse to the Fielder XTA, navigating in the subintima. I've reshaped it, not so much as a CTO curve, as we need its polymer jacketed properties to navigate through the planes of dissection. But if this doesn't work, we're going to move on to the Mongo wire to see if we can get ourselves through. I don't know. Change de vue. Je vais prendre le Mongo. 10-40 droit, 30 droit, 30 ans. Ultimately, attends, let's get it. This is test.
So you can appreciate the tortuosity and the calcifications of the diagonal. We switch views. This is RAO cranial view, 30-30. And we will still attempt with the fielder, but if it doesn't work in the next couple of seconds, we'll switch it for the Gladius Mongo.
Yes.
Yep.
I might just one other attempt with the fielder. As you all know, it's Fielder XTA's 1 gram. Whereas, non, attends, juste essayer. The Mongo is 4 grams. And it's a tortuous entry into calcified and tortuous entry into the diagonal. And the diagonal is the main challenge here. Ultimately, we could always star it. If we star it, and then we would call this an investment procedure. Ideally, there's no major side branch. So doing a star, as described by Colombo in 2005, will allow us to recoup the distal bed. I'm pulling back, as you can see, I'm pulling back the microcatheter, not to be too engaged in the lesion, in the dissected region, and I'm lowering the PSI so we don't further increase the dissection planes. Vas-y, test. Test encore. Test. Test. No, it's very tortuous, so
we're subintimal all the way.
Yeah, I think need a bigger curve. Ciné? Vas-y. Oh.
Go.
We've crossed the first curve, but there's more calcium. The tricky lesion. On multiple occasions we think we're through, but then we're stuck at a dead end. That's the tricky part with these calcified lesions, as most operators know. Test. Non. 10-40 gauche. Garde celle-là, rejoue-la. So Robert initially mentioned that we were gonna maybe consider hybrid revas. So hybrid revas, some operators will say that there's not that much data yet. It is a different modality. We have chosen as an institution and as a heart team to further advance our program in hybrid revas. There hasn't been any randomized data yet, some might say. It is a different modality for surgical intervention. However, I think it favors patient recuperation in a much easier fashion. In well-selected cases, within the coming week, the patient is back on his feet instead of that regular 2 months post-CABG and sternotomy with all the risks that is involved with sternotomy. That being said, we have this the luxury of having two premier surgeons that have elevated our program and will allow us within 48 hours of the mid-cab robotic to go in with clopidogrel and attempt to do the PCI test. D'accord. Est-ce qu'on a le mango?
We're still subintimal, but I think this looks
A bit more promising.
encouraging.
Test. Regarde celle-là?
Does it feel subintimal?
No, actually,
No, it
it's
feels
rather free. So
Rather free.
test. There you go.
Yeah, that looks
Regarde celle-là.
intravascular.
So we went back in with the field XTA. So with CTO, as you know, antegrade is much more problematic in terms of maintaining our volume of contrast down. Test encore, stabilité. Okay, encore dedans. So the carol, as you know, is 1.7 French, the distal tip. It's not going through. This is a sort of a slip and slide catheter, as operators know. Test. Whereas the Corsair Pro XS is 2.3 French. And I think
Shall we swap it for the Corsair?
We'll swap it for the Corsair Pro X.
Lower profile, and
even though this profile it's lower, we can't move forward with this. So my tip has been damaged. So it's okay. So what we're gonna do is we're gonna trap this.
Mm-hmm.
And go in with the Corsair. The goal would be to go in with the Corsair afterwards. Pro XS. À vrai dire, non. Là, on va essayer de le faire. Attends. On va le faire avec ouais, yeah. We'll use the indiflator. Ouvre le Y pour moi. Non, on pourrait. On est déjà là. Okay. Now I'll switch. Since it was tough to wire, I'll take the. Attends. Attends un peu. Copy.
Just going to air glide the microcatheter. Water glide the microcatheter from to the patient rather than trap it.
Attends un peu. Okay. Il reste en place.
Mm-hmm.
So as you saw, I used the indiflator, and then we switched out the microcatheter. we'll flush it, and then we'll take the Corsair Pro XS, which is 135 centimeters. Laisse aller. And we'll use a trapping balloon as well, the 2.5. So I air glided it out, and now we're gonna switch microcatheter. We had anticipated, as you saw, we were already ready with this microcatheter, the Corsair Pro XS, so that we anticipated. Tu l'avais essuyé, hein?
Ouais.
Ah, c'est ok. Attends un peu. On
Going
va
to
prendre.
trap.
Il est où le ballon? Le 2.5? Ah, ok. Je vais te laisser.
Going to trap the wire.
So, as you know, if you want to trap 2.0 for 6 French, 2.5 for 7 French, since, as Robert mentioned, regarde ce copie, we were in 7 French. We took a 2.5. La gonflette,
Okay.
s'il te plaît.
Trapping on.
Ah, attends. I think we're having some technical, no problem. We had some technical issues. My bad. I had, so you're seeing variations. Some people will like to prepare the balloon with a syringe. Sometimes we don't. So we inflate to 12 atmosphere about.
Okay, and I'm
Now we're
advancing
trapped with a
the
2.5. We're
microcatheter.
keeping an eye on our wire.
See, the wire is not moving.
I don't know if you see, the trap is there. And the wire has not come out yet. The wire is not moving. And we're getting close to. Okay, stop. Trap off. So now we have the wire, have access to it, and we're pulling out. Dana, j'aurais besoin de toi.
Just going to make sure there's no air
Yeah, okay.
trapped in the system.
So we're going to try to move this along. Recentre-moi. Laisse aller du micro.
So let's see if the Corsair
Makes its way
goes
through, as
through.
you saw. This is what we do now, I think, with modern day contemporary PCI. The issue is with laisse aller du guide. So counterclock with the Corsair,
And we made
as
it
you
through.
see. Counterclock 10, clock 10. OK. Regarde celle-là. Oui. Est-ce que je peux avoir... Oui, so there's two ways. Je peux avoir un BM2. So there's two ways of verifying that... non, pas de mango. There are two ways of verifying that since, as you know, we were in a subintimal plane, extra plaque, some would say, extra plaque, we want to make sure that before deploying our rota that we are actually all the way through. There's not so much concern if we're in between lumen and true lumen, if we have any dissection in between. However, we need to make sure that distally we are through. So this is like, I guess, CTO-based techniques for everyday PCI. I'm going to take some contrast. So there's two ways. So either with contrast or, so I'm going to do the first one is, if I'm not too concerned, sometimes I'll do the, ah non, pas besoin, c'est un BM2. So the two techniques to verify that you're in a true lumen after traversing, this is something that you can use everyday PCI is once you've crossed into what you believe is the true lumen with your wire, your specialized wire, you switch out with a microcatheter. Il y a un petit peu de tension sur le guide en arrière. So you can verify with a workhorse, or you can verify with a micro catheter injection. So the safer route, if you think that you're distally in a distal dissection, is to use a workhorse, which we have now, a BM2. If it navigates through nicely, then there are chances that we're not. However, if we are, then by injecting distally, then we might be more in trouble. You saw initially. Okay, so this
That
is.
looks free.
Regarde celle-là.
So just using the BMW2, we see how the wire moved distally, and this suggests that we're intraluminal.
Yep.
Could also have done the microcatheter dye injection,
Yeah,
but this is
wait.
the less safe route because we could be extending the dissection plane if we're in a dissection plane.
I'll make sure. Okay. Je peux-tu avoir la petite seringue tout à l'heure? Ça, c'est le BM2. On peut le ranger.
So we're going to try to do a microcatheter injection as well.
Or the other thing that everybody knows is that if you have blood coming
There's
back,
blood
I don't know
bitter.
if there's blood coming back, that's a good sign. A good sign that you're in true lumen.
Yeah, we draw black. We draw black blood from the microcatheter, which is a good sign. We're going to do.
Centre-nous un petit peu, Lucie, s'il te plaît.
Going to do a microcatheter dye injection.
So there
And
you
we can
go.
see the distal bed. So this confirms
So
that
this
we're
confirms
true lumen.
We're
distally.
true lumen, and then we can move on with the rhoda.
So we're going to
Alright.
do rhoda in this case, like mentioned, just because of the tightness of the lesion.
So there's a lot of questioning around calcium modifying techniques and strategies. As you all know, the plain old balloon is just no longer enough. There's also the scoring balloons or the Wolverine balloons that are actually quite interesting as an initial, I think I would say, first line after POBA. But then you move on to the still balloon-based modalities such as the OPN, high pressure balloons, even though perforations have not been that prevalent, even though you can sometimes go all the way up to 35, 40 atmospheres. You have, as everyone know, also now the possibilities in the last, at least in Canada, in the last 4 or 5 years, IVL. All right, so the shockwave balloon has sort of done its way through our landscape and made it much safer for all of us to tackle such lesions. Peux-tu juste ouvrir le Y?
So we shuffled in rhoda
It's a
extra
rhoda extra support.
wire just because of the tortuosity and the calcification. We
anticipate some resistance. So
exactly. So we want the additional support provided by this wire as opposed to the rhoda floppy.
So as I mentioned, there are balloon-based calcium modification techniques, and then there are what some people might say the bigger guns: rotational atherectomy and orbital atherectomy. And orbital atherectomy and rotational atherectomy are two different beasts for those who have already tackled them and used them. Even though there's differential cutting and ablation, the mechanisms are not the same ultimately. One of the advantages of rotational atherectomy, as I mentioned initially, is that we have ability of going through dissection planes, such as in this case, whereas orbital, just by the nature of its mechanism, might extend a extraplaque subintimal tear, whereas rhoda, despite the fact that it has less of the advantage of having a antegrade only ablation technique, the orbital has both retrograde, pas tout de suite, attends, parce qu'on va ouvrir, both the retrograde as well as an antegrade ability to ablate. Est-ce qu'on a ouvert le soluté? So as you know, rotational atherectomy is the old, I guess, the old dog on the field in terms of atherectomy, and it requires us to have some recipe that varies from operator to operator with the rotaglide, and some will add verapamil, nitro, Obviously, the ACT has to be kept between closer to 300 than 250. And most operators nowadays will go for the,
Want to test?
so most operators nowadays will go for a 0.8 to burr to artery ratio. Est-ce qu'on est prêt pour le rota? J'ai besoin de quelqu'un ici. So this is a team effort for rotational
In this
atherectomy.
case, just because of the tightness of the lesion, we're going to go very high speed to prevent burr
180,
trapping.
t'es prêt?
So we're going to aim for 180,000
RPM. Rebaisse à 180. So it's always good to check that everything is well connected. Okay. So
Good.
we're good.
So we're starting higher RPM just because we want to prevent any bird trapping.
Attends.
So we have basically the RPM
Veux-tu
can
le
drop
faire
more.
Tout seul ou tu veux le faire à
À
deux?
deux. À deux.
À deux. Attends.
And basically the RPM can drop more
Vas-y.
if we start at a higher rate.
So this is a two-man operation that we're doing. Vas-y. But as you know, you can also do a one-man rota. Pull up. Vas-y. Stop. Tu me tiens. Ok, vas-y. 2 secondes, stop.
So we're two operators, might as well use the extra pair of hands, but
Usually when we do this alone, as Robert, I think, wanted to hint at, I'll let him concentrate, is a one-man show where we can actually loop it.
the wire distally. It's
I want to pull back on the wire.
pull back on the wire.
Back on the wire. Attention au guiding. Ouvre le Y. Okay, we've pulled it back a bit. Okay, vas-y. We're starting with 1.5. I find that. Go ahead. Vas-y.
Amène plus près.
Ouais, excuse-moi, sorry. Vas-y. 1.5.
Just
1.5 stalls less. Sometimes we have to ablate a bit going in.
yeah, it's possible.
Yeah.
The wire is very it's too advanced, I think, distally. We could pull back just a little bit so we don't get any
Release the brake.
perforation. Release the brake.
And it's even tougher to pull back. So I think we better start with this and then exchange it out afterwards.
Okay.
Okay. Tu veux le faire ou-
Yeah. So we're going to just this is what size burr? It's a
1.5
1.5 burr.
1.5 burr, which is going to advance it. Sometimes you have to advance it a bit.
Okay.
C'est de l'avancer un petit peu encore. We're going to try to advance it if you can
Yeah, in the left main.
in the left main. Then
We're
you can
happy.
advance it slowly.
Just going to
Is it gonna do the
ablate the
first?
LED.
Lentement. Correct, continue. Arrête pour avoir de no recourse stop there.
Okay.
Regarde celle-là.
So
Does
we
you-
heard some tonal decelerations, and I'm not sure how low it went. 163, so
There's a-
not too bad.
20,000 RPM drop. So
Deceleration.
if some of us prefer to start with a low, which is more typical, you might have gotten closer to the range of 130, where you will definitely be closer to Dynaglide, and then the risk of burst stalling. So that's our preference to go with 180. Maybe do another run proximally,
Mhm.
and then in also there where there's noises. Là, oui, là, avance un peu encore. Reviens sur la diagonale. So what we're discussing where to ablate the stuff. We're going to do three runs, giving time. And this is sort of there's really no way that anyone, most operators for rotational atherectomy and orbital atherectomy have their own ways of doing it. I'm not saying that mine is better, but I think it's a question of giving time for the artery to breathe, quote unquote. So we're giving a good 20-25 seconds between runs, so there's no issues with slow flow, as this is an important territory. Maybe we'll do a bit more in the prox segment of
rather
the
than the
diag. And then we'll switch out to 175 Yeah, there. There's the noise. So now there's less noise. Avancez un petit peu encore. Un peu dans la diago plus loin. Bon. Ouais, là. There you go. You see the noise? Hear the noise? Okay. We're good enough with that. Okay, so we're good. We're going to dynaglide out.
Mm-hmm.
So dynaglide mode.
Turn it on.
Release the brake. And we're just going to switch out. I'm just going to stand here and let it snake out as most operators know how to do. This is a sort of a one-man operation. The only thing we have to be sure is to turn it off right before it splashes everyone, which will be soon. And we have it out.
Very well
Right?
done.
We're going to get the 175 burr out just to do
It's
the
a
prox.
1.5 burr. Yeah, we're going to swap it for the 175.
As as I mentioned initially, and then I sort of had to move on with the procedure and give a hand to Robert, is that nowadays most people will adopt the 0.8 burr to artery ratio. The more aggressive operators will go for a 0.5 to 0.6 burr to artery ratio. Est-ce qu'on peut avoir la burr 1.75 s'il vous plaît? And right now we're estimating visually, of course, we'll
At least a
confirm
3.5.
by OCT that we have at least a 3.5 to close to 4.0 caliber in the prox LAD, hence our move all the way up to the 175 burr.
Yep.
We're just waiting for the burr to be opened, the next burr.
But also decrease the fluoroscopy intensity if possible.
Est-ce qu'on a la burr 1.5 dans la salle, s'il vous plaît? 1.75? Elle était là. Ouais. So yeah, so as you saw, once you pass through, I think one of the advantages that we got, it's always about having a sort of a growth mindset. We ran into some issues initially with a dissection plane in the prox LAD, and this sort of gave us an advantage because now, even with the microcatheter, you saw the Corsair Pro XS go through. Whenever you dissect through, it sort of allows us to defeat some of the calcium that is intraluminal and at the intimal level. And then we just have to navigate around the calcium, which we ended up doing. Attends, je vais te le faire. So as we all know, when we get the rotor, I think nowadays in 2023, the most challenging part of doing rotational atherectomy is assembling it. We have to all get comfortable with this. I think we were discussing Renovate Complex PCI that was just released at ACC and published simultaneously at in New England. But you won't be able to get the results you want to be confirmed by imaging, such as stent expansion.
We'll just do a cine to see what it looks like.
Position. Go ahead. Close. We're trying to limit our contrast up to now. So we have spasm. Est-ce qu'on peut donner un bolus de 300, puis on va donner nitro, nitro 1, bolus de 300. Si la pression après que tu contrôles dans 2 minutes, la pression baisse en bas de 100, tu peux donner un néo 3. So as you saw, which can happen after a dissected vessel that has undergone rotational atherectomy, these are things that can happen, so it's not a major concern. The patient is very stable. He's got a 118 of systolic BP. His heart rate has not changed, which is around 62. So things are going according to plan. And then we're going to just do the prox segment of the LAD to make sure we'll be able to achieve full
good expansion of the
expansion. I think one of the advantages, and this is where some operators who are not keen on atherectomy modalities might get a bit comfortable with.
Don't move, sir.
Sure. Bougez pas.
Keep
pas,
your
monsieur.
hand down. Everything is going well. You can tell us, and we can scratch your forehead.
So the other thing is that IVL will allow you the ultimate parameter, intracoronary imaging
Things are
parameter that
going
you
great.
want, which is stent expansion. However, it doesn't necessarily favor delivery. So this is where I think atherectomy strategies are complementary, and rotational atherectomy will get rid of all these spicules as well as a bit of the subintimal, not really the subintimal calcium, but some of the intraluminal calcium that will allow you, prevent you from
You have it.
getting
Okay.
stent delivery. So, and having macerated the lesion in the diagonal, chances are that we'll be able to get expansion as well. Because as the OCT studies in the disrupt study, we were shown by the disrupt OCT data, the name of the game is to get fracture of the calcium plates in the media to get your expansion. Stop. Un peu. On est pris.
Pull back on the wire.
Yep. Give me a second. Pulling back. Sorry. Back. Yep. There you go. All right.
Okay.
Garde celle-là.
We're in position. So we will use the 175 burr only in the prox LED section.
Yep.
We won't go in the diagonal.
Release it un peu. Ouais. Ça qui jump pas. Est-ce qu'on peut. Attends un peu. Non, non. 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 Attends ça.
Release the brake.
OK. Est-ce qu'on peut avoir quelqu'un? 180 encore. T'es prêt? Prêt? OK, go. Vas-y. Vas-y, c'est beau. Pas trop dans la diagonale, on va la perforer. Ouais. You hear the noise of the 175. OK, garde celle-là. No evidence of slow flow, no EKG changes. The heart rate is still around actually 70. BP is 118 again. Vas-y. One last one. Rentre pas dans la diagonale. Yeah. Okay, I think we're good. We're good to go. Montre-moi, scopie. Ouvre le grec. On va prendre le Corsair Pro XS. So we're going to exchange out our... Je vais prendre un BH, s'il vous plaît. Get BH. So we're going to get a more supportive wire. We're going to get our previous Microcatheter, Corsair Pro XS, to exchange out the rotor wire.
Okay.
To exchange out the rotor wire for a more sturdy, supportive wire, which will be the BH wire.
So we got the 175 burr out, and we'll put the microcatheter in. Chest pressure. 50 of fentanyl, please.
50 de fentanyl. On va se dépêcher, on va donner de la nitro probablement. Je vais prendre une pression. Faut que tu me laisses le guide.
I think it's watch out.
Ouais, non, c'est correct, je vais. Enlève ta main, attention. Okay.
Je vais prendre la nitro. On peut donner 500 cc de bolus.
Il est déjà en cours. Je pense qu'on peut donner un peu
cc
de
nitro.
T'es prêt? On va se dépêcher pour ça. On va Excuse-moi, Lucie. Attends. Non, le guide va se briser. Un peu. Attends un peu.
We're just going to get our microcatheter in, and then we'll take a cine
assess.
after. Pull back.
Le BH, t'as pas besoin. On a
Pull back on the wire.
Yep. Doucement. Ouais. Encore. So as you saw, very smoothly. Avant ça, une petite affaire de plus loin. Juste pour être sûr qu'on passe bien. OK. OK. Garde celle-là. Pas besoin de la gonflette incessamment.
Going to get the BHW.
Merci.
I already has the tip.
Ouais. Correct. Oui, poubelle. Ouais. Merci. Alors doucement pour pas perforer distalement. We're going to exchange out as we did previously. Air gliding it out. That's perfect. C'est beau ça. Ouvre ton Y.
Ouais. Just,
Laisse-le comme ça. Tiens ton Y, ça va être plus... Vas-y, tiens l'écran, je vais m'occuper du reste. As we did previously in the other, with the other wire, we're just going to switch it out.
Air glide it out.
And I think we're good.
Now we can reassess. The pressure is a bit low, but I think that could be my
Néo 2.
nitro. I'm
Néo
just going
2.
to take a cine to see.
Everything's good.
Yeah,
So
everything's
it's
good.
probably some micro part. Regarde celle-là. Néo 2. Tanya, Néo 2. Pressure is a bit more on the lower end. We're closer to a, there's a bit of a gap between our actual, as you can see, our pressure cuffs versus
How much is the
our
pressure?
monitor. Okay?
Gone?
OK. OK. On va
You're
prendre.
back?
Regarde, remonte-moi cette image-là,
Things are going great.
la plus récente. So there's some dissection. So we're going to take the OCT out and we're going to do some imaging now. On va prendre d'autres nitros. La nitro est à jeter. Il y avait trop de sang dans la nitro. C'est ma faute. Okay, cleaning things up in between steps of our plan. Our plan is going according to what we want. Il est un petit peu plus vagal, ça prendrait la Neo 2 si c'est pas donné. OK, on peut, peut-être qu'on a flashé. Donne-lui un Neo 3 encore. Commence à être un peu plus radical. Maybe the flush of nitro. As, we're giving him a little flush of saline, 500. And we're going to add some
Pressure is slowly coming back up.
But as you saw in the most recent image, montre-moi l'image, the fluoro save that we did. Est-ce que tu peux me montrer l'image qu'on vient de faire? The fluoro save that we just did, there's less spasm compared to the initial. So as we all know, this is the price we all have to pay for a more vasodilated artery. Nous, celle juste avant où il y avait le spasme. Avant. Ah, on l'a pas sauvé. We didn't save it. Prochain.
No.
There you go. So this, montre-nous celle-là versus celle qu'on vient de faire. So this is what you're seeing post initial 1.5 burr. Now I'm going to show you the post with a lot more nitro. You can see the distal bed is lightened up. So that's actually very good. L'OCT. So some people might favor going more towards NC balloon to make sure you have full expansion before
Doing a stent, yeah.
putting in, doing imaging or doing a stent. But I think we're all used to this now. We're going to favor imaging before. Excuse me, Robert. I'm just going right in front of you to get the ACT rolling. So instead of going angio-based only, sizing with balloons, which is, you know, what we've all been taught in a certain way on a daily during our training. I think the better part of what we want to do now. ACT sur la table. Tu me sais? Vas-y. We're going to bring down the dragonfly. The OCT catheter dragonfly will allow us to get a better, some might, you know, with reading the Renovate Complex PCI study, they left it to the discretion of the operator which intracoronary imaging modality we wanted, the operators wanted to use. I believe the better assessment in terms of volumetric assessment of calcium burden is with the OCT. Yeah, that's good.
And you can appreciate we had issues initially just passing the Caravel microcatheter,
Yeah.
but now after the 2 ROTA runs, there's absolutely no resistance on the BHW to advance
Regarde celle-là.
the Dragonfly.
Puis est-ce qu'on est prêt pour le Dragonfly? So pressure is all the way back up now. Prends-nous un autre brassard, Tania, s'il te plaît. Patient has no longer any
Let's
chest
see
pain,
if
so
we get
This
Side
is
view.
typical.
Just going to check the wing. Okay. Let me
Okay, on est prêt à calibrer.
calibrate. For 18. 18.
4 et 16 ou 18,
Ou
toi, tu veux?
18, mais je l'ai pas au
Ok,
complet.
c'est correct. 300, hein, je
Ouais.
pense. Make sure.
There's good clearance.
Ok, est-ce on est prêt?
We're actually going to
l'OCT?
do the full 75 millimeter.
Yeah, yeah.
So let's change the pullback type from high res to
Mais nous, 75,
yeah,
the pullback type.
auto calibrate. At the
Alors, en
bottom
bas,
right, auto
yep.
calibrate. All right.
Oui.
We're enabling the pullback.
Oui.
Ah.
Vas-y. Perfect.
This is good run. We're going to remove the OCT.
I think
So then don't get more spasm.
There's no spasm. There's good entry of the contrast, no loss of contrast. The guiding was well intubated, so quality image should be quite helpful for us to judge what to do. While we're looking at the OCT imaging, we have 113.
You can see a lot of the calcium fractures. There might be some.
Yep, there's some calcium fractures, as you can.
We see the rhoda tract.
Yep, the nice circular track. I didn't see any yellow duckies. Oh, maybe. So see, you see some of the arc of calcium around the vessel. So this is extending beyond the 5 millimeters in terms of length, obviously. It's 360 deep calcium, 5 millimeter of depth of the calcium. Also within the main LAD vessel. So in terms of the Fujino score, this tells us that we did a good choice in terms of getting some calcium modification techniques going. So there's currently, as you can see, some of the deeper calcium at many levels. So we're going to try to, okay, stop la run. Essaie de me trouver la bifurcation avec l'IVA, s'il te plaît. So we're going to try to look at the prox LAD.
I think it's around
That's
35
awesome.
millimeters.
That's the prox LAD.
Como distal at 35.
So that's, you see the heavy calcium burden.
Yeah, circumferential calcium.
It actually grows a bit more. This is where I think we're entering.
Yeah, I think.
Yeah, this is.
I wonder if that's the
prox. Go. Okay. Prox diagonal. Va plus loin. 30. So we're in the diagonal now. That's for sure.
Mm-hmm.
So you see some of the dissection irregularities from the dissection planes that we were in before. Continue. Continue. So you saw the false lumen go by around 7, 8 o'clock. Then va juste au distalement, dans le lit distal. Plus loin, plus loin, plus loin, plus loin, plus loin, plus loin. Là, là. Encore, encore. Là. Stop. Looks like a side branch. It's pretty deep. Fais-nous une mesure de.
This is a 225 by 225 vessel.
Yeah, it's max.
Distally, and that's what we anticipated.
Yep.
Around 2.5 in the diagonal.
So it's going to be a long stent.
Long stent.
2.25. I don't think we've have enough dissection and fracture of the calcium that we needn't worry about what to do in terms of the diagonal. Le plus long stent 2.25 que vous avez. Le plus long stent 2.25. And then what we have to decide is whether we need to use IVL. The delivery won't be an issue, I think, but the calcium might not provide us with full expansion. So we might have to pull out the shockwave balloon. Est-ce que tu peux revenir à 50? If we go back to the 50 millimeter mark. Remonte. So you see right here, where it doesn't seem to be that stenosed, but it's tight enough. We have circumferential calcium close to above 270 in terms of arc.
Yeah.
The depth is clearly beyond 5. And then if we go back, va 35, 35, là. So, enlève le contour, s'il te plaît. Okay, so you see where we're starting to get into the LAD from the diagonal. Est-ce que tu peux reculer, s'il te plaît? Pull back. Non, dans l'autre sens, vers la prox. So you see the burden of calcium says that it might require... Stop là, fais un contour. We're just going to measure. So we're at 3.65. So getting a 3.5 shock wave might be a good assessment. Recule. Va dans les 50. Encore. Stop là. On va le prendre. Bon, moi, so the mean diameter is around 3. Around here, 3.5. Encore, recule encore, vers les 50. So this is tight. So as you saw, there's a big gap in terms of and the lumen is circular, as you can typically see by OCT when you do ROTA. So subsequently, recule un peu plus. So this is a lot of calcium. So I think what we'll do is, do you want to stent the LED, the diag first, and then do IVL?
We take care of the diagonal first, get it out of the way. Then we'll have to do IVL. I don't think the...
Okay. Right. So we're gonna keep on. We're gonna stent the
diagonal, and then we'll do IVL for the prox LED.
And then we're gonna move on. On peut sortir le shockwave, un ballon 3,5 par 12, s'il vous plaît.
You can appreciate the rotatracts in the diagonal that we caused just because of the sizing of the burr versus the size of the vessel. So while I think I'm pretty confident we're going to get very good expansion in the diagonal, in the LED there's still more work to be done just because of the size of the vessel.
So this is where I think
IVL is going to help. OCT does not allow us to assess the deep calcium that IVL can, but we can assume just by looking at the angiogram that there is both superficial and deep calcium.
You mean IVUS? IVUS is not. IVUS doesn't allow us to assess deep calcium as much as OCT does.
Exactly, sorry. Okay, so no issues there.
Montre-nous l'image de l'OCT. So I'm just going to use the OCT as a benchmark of where we should stop our stent. So
by that second branch,
the
in between the second branch going off.
Go ahead.
Okay.
Okay, on est correct?
Ici?
Ouais. Montre-moi. So as you see, this is more of the standard PCI now that we're all used to. We'll likely... oh, attention, guiding. Attention, ton guiding, tu vas disséquer le tronc.
You want
to open up? Attention à ton guide, c'est allemand aussi. On était à 12, là on était à 16, 18. So we're going to likely head into a...
There is some resistance here.
Dégage, ouais. Ouais, c'est correct.
Good. Yeah, the wire, I saw that.
So our plan is to do a... So as you saw, this can get more complex than this, I guess. We're gonna stent the prox diagonal, and then stent the prox LAD, and then see what we can do. And as discussed, the CTO can be reassessed for PCI in a later time
versus
point
mid-cap.
Versus mid-cap robotic, which is much less invasive and more prone. So the plan now is to move towards a more of a standard PCI of the prox LAD into the diagonal. On va prendre le IVL. On va prendre le... So time is running short, and I know your team needs to wrap things up. So basically, we need to still add an extra calcium modality. Wait. And then we will stent. So for those who are watching, thank you very much for attending. As you know, this is everyday run-of-the-mill PCI in that Time points are not something easy, but I think we showed you some very interesting concepts here, CTO-based skills to get through dissection, atherectomy complemented by intracoronary imaging to really get optimal stent deployment and delivery. So I hope this was fun, and I thank your team, and I also my partner in crime, Dr. Avram, and the team at the Montreal Heart Institute for taking part in this great event. Thank you very much. Hope to see you soon. Take care.
Thank you very much.